wife of Mr. Nakash, 26 years of age, did her bachelor's in arts, married for 2.5 years, a housewife, resident of Sahiwal, house number 24, Street 4, Block U, Gulshan Usman, presented with the complaint of primary subfertility at Hamid Latif Hospital, dated the 1st February 2021 at the Life Center. Her last menstrual period is 17 December 2020. She presented with the complaints of infrequent cycles since menarche, unable to conceive for last 2.5 years. History regarding infertility. It's the first marriage of the couple, living together for 1 year. Their coital frequency is 2 to 3 per week, with no any coital difficulty, dyspareunia, or postcoital bleed. Her husband is 30 years of age, with a height of 5 feet 4 inches and a weight of 70 kg, with a body mass index of 26.49 kgs per meter square. No history of asthma, tuberculosis, diabetes mellitus, or use of any antidepressant drugs. No history of smoking. No history of ischemic heart disease or any childhood history of mumps. No history of undescended testes, testicular torsion, trauma, or varicocele. Mrs. Nakash, her menstrual cycle is irregular since her menarche, with the amenorrheic spells of 2 to 3 months, followed by a spontaneous menstruation for 5 to 6 days, soaking 1 to 2 pads for the first 2 days and just one pad for the latter 4 days. No any complaint of dysmenorrhea, dyspareunia, intermenstrual, or postcoital bleed. No history of per-vaginal discharge. She gives history of weight gain for last 3 years and she has gained up to 8 to 10 kgs of weight, but no associated history of acne or unwanted hair distribution of the male patron. And she didn't use any contraception since the beginning. And in spite of the regular frequent intercourse for 1 year, she is unable to conceive. She took 3 cycles of ovulation induction with clomiphene, and the last she remembers she took in March 2020. She took this medication from her local general practitioner there in Sahiwal, but after inquiring from the patient, her ovulation status was not checked and followed. So it was unsuccessful. Her tubal patency is not checked in this period. No history of dye handling or Hakim medication. The fertility workup, which is done up till now. She is here with her transvaginal ultrasound dated the 2nd February 2021, which shows the polycystic ovaries and the endometrial polyp of 10 into 4 millimeters. And her husband's semen analysis is there of the same date, like that is the 2nd February, showing all the normal parameters. That is the sperm concentration of 76 millions per mils, total sperm count per ejaculate of 152 millions, and total motility 38%, and the normal forms of 6%. No history of hypertension, diabetes, asthma, ischemic heart disease, tuberculosis, or thyroid disease. She has maintained her hygiene well. No history of drugs, smoking, no history of allergy to any drug or known common allergens. Her husband is running a medical store of his own, living in their own house, meeting their expenses well. Patient's mother is diabetic type 2. No history of endometrial, breast, or ovarian cancer in the family. Her age of menarche was 13 years, and as I told earlier, her menstrual cycle is irregular since the menarche, and she has periods for 5 to 6 days every 2 to 3 months, soaking 1 to 2 pads for first 2 days and just one pad for later days. And there's no any complaint of dysmenorrhea, dyspareunia, intermenstrual, or postcoital bleed. She has not used any medication to regularize her cycle up till now. No history of discharge per vaginum. No history of pap smear taken. Her last menstrual period is 17 December 2020. She is nulliparous. No history of shortness of breath, any chest discomfort, Her S1 and S2 is audible with no added sounds. She has got the normal vesicular breathing and no history of cough, shortness of breath, or fever. No history of nausea, vomiting, epigastric discomfort, or constipation or diarrhea. No history of headache, dizziness, tremors, and syncope. A young lady sitting comfortably, well oriented in time, place, and person, with a weight of 75 kgs and height of 150 centimeters, that is 4 feet and 11 inches, with a body mass index of 33.3 kgs per meter square, with vital signs of pulse 82 beats per minute. Her blood pressure that time was 130 by 90 millimeters of mercury, respiratory rate 16 per minute, and her temperature documented 98.6 degree Fahrenheit. Her teeth are natural, fixed with good dental
I,
hygiene.
I think we stop it. It's a good issue, good issue. And we will not go into details of her general physical examination.
Ji sir.
Yeah. Um, you have given this history in great detail. You have not missed anything or left out anything. And I may tell you that it has taken only 5 minutes to do that. This is important information. That even if you have a longish history, details like this about husband, about wife, there were some points in the history which you highlighted. In spite of all that, there, you took only 5 minutes, which is just about right. Just about right. So, the message home is don't rush through history. Always say, bring out the salient points or the important related points to the problem. Here, the problem right from the word go was that she's been married for 2.5 years and has failed to conceive.
Conceive.
Subfertility, primary subfertility. That's the terminology used these days. So, the message home after this history is that even if you have the longest history, you have to say so many things about diet, about height, about their profession, about everything, allergies. Still, go on with it as slowly and surely as you did, and don't just rush through it or don't omit anything. This is one message. Now, the second thing which I would like you to do is let's have a summary of this history. Make a summary and present that. Same patient.
Uh, mhm. Sir, my patient, Mrs.
Eh,
Ikra Nakash.
Did you make a summary already, or you are going to
No, no,
make it
sir, I'm just making, I didn't make actually earlier.
now? So never mind. Now I could see that. See, examiners are very clever. They, they know exactly what you had done or you were going to say off the cuff or make it up. So that's the second thing. When you finish the history, make a summary.
Hmm. Sir.
Because generally speaking, the examiners are bound to ask what is the summary or what are the important features, what are the important points in this case. So you have to highlight them. You have to
Hmm.
right. So make it a habit. It will take you only 1 minute to narrate that summary. But if
Hmm.
you had already done it, it would have been organized better.
Hmm. Exactly, sir. I just
You
missed.
won't have missed anything.
Hmm.
Now, if you're going to make it now, there are bound to be some points which you will be missing.
Hmm.
Okay, let's still have the summary of this patient.
Sir, my patient, Mrs. Ikra Nakash.
First thing,
Mhm.
in summary, name is unimportant.
Okay.
See, this is the difference. If you had already prepared, you would know. Because in summary, we are not interested in a name, address, things like this. Is
Hmm.
exactly the summary is going to help us in physical examination, investigation, treatment. Name is our name in full history is very, very important for identification.
Mm-hmm.
You gave details of her address as well in Sahiwal. And we perhaps don't need that detailed address, house number so and so, and so mohalla. No, but that is okay with long history. In summary, when you are asked, give us summary, you don't give the name, start with the age, because age is important.
Mm-hmm.
And similarly, husband's age is important, right? Then on. Okay. Again, let's have the summary.
My patient, 26 years of age, and her husband, 30 years of age, married for 2.5 years. First marriage of the couple, lived together and presented with the primary subfertility at Hamid Latif Hospital, and with the basic workup of transvaginal ultrasound done and the husband's semen analysis. Husband's semen analysis is normal, and the wife's transvaginal ultrasound showed the polycystic ovaries. And she,
Just if we are going to say husband and nurses here, say coitus is also regular and normal.
hmm, okay,
Because
sir.
in long history, you said coitus is every 2 to 3 days
Three
per
weeks, regular, exactly, sir.
for subfertility. They are
Hmm.
together, and coitus is 2 to 3 weeks, and semen analysis is this.
ठीक
And in semen analysis, in summary, you will say three features: um, total count, motility, and morphology.
Mhm.
Okay. Have the
Yes. So
summary again.
again, my patient, 26 years of age, her husband, 30 years of age, married for 2.5 years, presented with primary subfertility. First marriage of the couple living together. Their fertile frequency is adequate 2 to 3 per week, and they presented with a basic workup of a husband semen analysis, which is showing all the three normal parameters of sperm, total sperm per ejaculate, sperm concentration, and motility, and normal forms. And her wife has got the transvaginal ultrasound done, which shows the polycystic ovaries and endometrial polyp. And she has a complaint of infrequent cycles since menarche.
No. But there were few important things in the female history or wife's history. Her menstrual cycle is infrequent,
Infrequent. जी सर वो मैंने आखिर में
two
बताया.
to 3 months, and then that she has gained weight,
Hmm.
and there is no hirsutism or excessive growth of hair.
Acne. जी सर.
Are important components of history. Then, after giving history, then you come to the physical examination, then investigation.
Hmm.
She is 4 feet 11 inches, and her BMI you have calculated 33,
Point three.
and uh, so that's how you give the complaint. Transvaginal ultrasound (TVS) will come in investigations.
Hmm.
Like semen of husband comes in investigation. Okay, now you go home. You are at home already, perhaps. Uh, uh, keep revising how to make a summary. After 2 or 3 patients, you learn it. Now, here's a patient. I present the summary on your behalf. 26 years old, married for 2.5 years, has failed to conceive. Husband's semen analysis is normal. Her BMI is high, and but there is no hirsutism, and menstrual cycles are irregular. There is no relevant family history or past history. Is that all right?
Hmm.
Okay. Now, on physical examination, uh, I presume everything is normal. How will you proceed to manage this patient further?
Sir, first of all, I will go for the investigations. I will divide the investigations into the two, the baseline investigations, and the specific investigations. In baseline investigations, I will first recommend her urine pregnancy test because her last menstrual period was 17th December 2020.
Excellent.
So blood group with R.
This is the most important thing you have said. although this patient's menstrual cycle is every 2 to 3 months, and she had her LMP in December, didn't have in January, which is normal for her. But still, if the patient had LMP more than a month ago, you must do this test, which you have said. Excellent, excellent.
Thank you,
Then,
sir.
so
As,
the first important point which you have made is even if the menstrual cycle is irregular, infrequent, every 2 to 3 months, her LMP was more than 4 weeks ago, the first test you must do is urinary pregnancy test or UPT to rule out pregnancy. Excellent. Okay, you'll do UPT and add test.
sir, blood group with
Yes,
so blood group with Rh factor, complete blood count to see the hemoglobin, total leukocyte count and platelets, hepatitis B surface antigen, anti-HCV, anti-HIV screening, and according to the current situation, the COVID-19 PCR as well.
good.
Blood sugar, so random blood sugar, and the urine complete examination for the biochemistry. This will be the baseline investigations I'll recommend her. And as far as the specific investigations are concerned, she has already presented with the two important tests, that is the semen fluid analysis and the transvaginal ultrasound of the female. So I will go beyond that. I will recommend her the serum.
डॉक्टर साहब आपके एंड से ना इंटरनेट इंटरनेट थोड़ा सा स्लो है, सर को आवाज कम आ रही।
ओके सर, मैं ट्राई करती हूँ। हेलो सर, अब आ रही है आवाज?
ठीक नहीं आ रही, ठीक नहीं आ रही।
सर मैं अब ठीक करती हूँ। सर सॉरी, जस्ट गिव मी अ सेकंड। सर ठीक हो गया?
जी आप ठीक।
Sir, I'll recommend her the serum follicle stimulating hormone and the serum luteinizing hormone on the day 2 of the menstrual cycle and the serum prolactin. And then another important thing I'll go for is the tubal patency test of the patient. And there are two options for the tubal patency test. That is a hysterosalpingogram and the diagnostic laparoscopy plus the dye test. As the patient has presented to me at the Hamid Latif Hospital, which is obviously a well-equipped hospital, and the diagnostic laparoscopy plus the dye test is the gold standard, so I'll go for it. I'll recommend her to do this.
Okay.
Sir, then after doing the baseline investigations and after their results of the diagnostic laparoscopy, then I'll further go for the management.
So he has told me, first you will do husband semen analysis, which we have the report. As it is, if it is normal, so and coitus is normal, so we believe it is not husband factor. Is that right?
Yes, sir, exactly.
So once you have ruled out husband factor, whether it is responsible for her subfertility or not, so we move to the wife. So first message which you are giving me is, in the case of subfertility, the first person you like to investigate is the husband. And for husband, there are two important things. One, coitus, whether it is satisfactory or not. And two, a semen analysis and all the WHO criteria for that. If that is normal, then we presume that it is not husband factor. So we move to the wife. In case of wife, you said you'll do FSH, LH, and
serum prolactin.
You said wife's investigation, hormonal.
जी सर.
जी
सर सीरम FSH, क्योंकि सर TBS जो है वो उनका already we have with us, which shows the polycystic ovaries, so definitely we'll go for like hormonals like serum follicle stimulating hormone and luteinizing hormone on the day 2 of the menstrual cycle and serum prolactin. Sir, after this, I will go for her tubal patency test.
Anything else in hormonal test?
Sir, a thyroid profile. I'll go for thyroid profile as the patient is uh,
That's very good.
her
All right.
BMI is 33.3 kgs per meter square. Is
Good.
moderately obese. And sir, then I'll check her tubal patency.
We have
Uh,
not discussed her TVS. What were the findings?
Sir, I told earlier, her transvaginal ultrasound was done on the date 2nd February 21, which shows the polycystic ovaries and
Policy.
endometrial polyp of 10 into 4 millimeters.
Good. So TVS findings, you mentioned these. So in relation to these findings, would you order some hormonal investigations more than what you have said? FSH, LH, prolactin, and thyroid test. You have already mentioned.
This way.
Would you like to do anything more? Or these tests are okay?
Uh, Sir, I think they're okay.
Okay. I'll ask you, the TVS tells you that she has got PCO. This is what you have said.
This way.
On what basis PCO was the diagnosis made on TVS? On what basis?
Sir, it was written the complete matlab, follicular number, which were more than 12, and they're sorry, sir. They were not the dominant follicles, no? They were smaller in number,
Small, multiple follicles,
multiple follicles of 8
generally
to 9
along the periphery,
periphery exactly,
and generally
with
distributed.
increased ovarian stroma.
In case. So then we diagnose on the basis of TVS, she is a case of
Polycystic ovarian syndrome,
polycystic
PCOS,
PCO. And so this is a increased stroma, multiple small follicles,
follicles.
uh, generally distributed along the periphery, and that necklace kind of thing. And so on that basis, if the diagnosis is PCO, then uh, do you expect some other hormonal changes in PCO?
Sir, patient can present with hyperandrogenism, in which
Yeah.
the testosterone level is
So
raised.
would you like to do some other investigations for hyperandrogenism?
Sir, I didn't choose because my patient is yes morbidly obese, but there is no any history of like acne or hirsutism. So I didn't choose for the testosterone levels to be checked.
Okay, if all PCO patients are not obese, is this
Mm.
statement correct?
Yes, all obviously there's a lean body
All
mass PCOS too.
need not have hirsutism. All PCO patients need not have obesity, or but they can still be PCO.
Mm.
So, sex hormone binding globulin, the tests like that, would you do them or not? Would you ask for those tests to make a
Uh,
diagnosis of
Definitely, sir. I will. I will ask her for sex hormone binding globulins.
that kind of those
Mm.
enzymes
Mm.
related
Enzymes
to androgen? I think
because they are markedly
we'll
reduced in the
do those.
PCOS. So to confirm the diagnosis, I'll ask her for
So,
sex hormone.
what is the, have you heard of Rotterdam
Uh,
basis of making a
yes,
diagnosis?
sir.
Yeah, what
Ac-
is that?
Sir, according to the Rotterdam's criteria, polycystic ovarian syndrome is a heterogeneous condition which must include two of the three criteria. Number one, oligo ovulation or anovulation, that is oligomenorrhea or amenorrhea. Number two, clinical or biochemical presence of the hyperandrogenism, that is the elevated testosterone. And number three is the ultrasound assessment of the ovaries to confirm
So,
PCOS, which already discussed.
uh, if that is the criteria, hormonal changes are androgen. So we will try to find out whether she has excessive testosterone or sex hormone bonding globulin is low or high, whatever. Isn't that? So
Yes,
we'll
yes.
include those as well in this list.
Okay, sir.
In this,
Definitely.
because this patient has got actually two problems. One, subfertility. Second,
And another
PCO.
irregular cycles. Exactly, sir. Mhm.
So we'll include both these problems during investigation to find out whether they are there or not. For ovulation, you have mentioned FSH, LH, and prolactin as well as, and because she is overweight, you have included thyroid tests.
Thyroid profile, yes, sir.
So for the PCO, we'll include testosterone and sex
Six
hormone
hormone
bonding
binding
globulin.
globulins.
So these are the hormones you'll do. Anything else to know? No. This is the first line of investigation, blood test in this patient. You earlier mentioned that for subfertility, husband semen, you mentioned and we have confirmed that he is okay.
Yes, sir.
Second is the requirement that you will find out ovulation by these tests or any other tests you can do.
Sir, fasting blood sugar, as I already mentioned, or HbA1c,
For
we can do it.
okay. No, my question was that any other test you can do to find out ovulation?
Sir, we do serum progesterone on the day 21.
In this case, the cycle is
There is
2
exactly, sir. So we can do the
to a serum progesterone test, if at all, in this case.
so sorry, आपकी आवाज कट रही थी. I couldn't
On
hear.
which day you will do serum progesterone test in this patient?
Sir, in this patient, we can do the serial serum progesterone levels every alternative day.
Oh, well, that will be too expensive for the patient. If at all, we suspect that she may still be ovulating in spite of the fact that she is cycle 2 to 3 months. When does ovulation take place in a normal cycle?
So उसमें तो 14 डेट पे होती है ना ovulation in the normal cycle of 28-day cycle.
In a 28-day cycle, 14 days before next menstrual cycle.
Menstrual cycle.
Next menstrual cycle. Here we don't know. Let's say presume that her cycle is every 2 months. So we'll be calculating her LMP was in December. Next menses is due on 21st of February.
February.
So we'll take out 14 days from that. We'll do it on 7th of February.
Okay.
If it is 2 month cycle, that's how we work it out. Okay. On which date it will be what we call cycle 20, P21, P4 on 21st day. In this case, that 21st day will be on 7th of February.
7th of February. Exactly.
From LMP 21st of December. Normally, after 21st of December, in a 4 weekly cycle, it would have been easy to work out. But in this case, you have to work out like this. The duration of cycle is 2 months, not 1 month. Okay, we are running short of time. These are the ovulation tests. You already mentioned that you will prefer laparoscopy, not hysterosalpingography.
Yes, sir.
These two mentioned. Any
Yes.
other tests which can be done to find out tubal patency? You mentioned two,
Sir,
hysterosalpingography and
yes, sir.
any other test?
Yes, sir, through ultrasound जो करते हैं hystero like ultrasonography.
What's the name of that test?
सब मेरे जहन से इस वक्त निकल गया मैंने पढ़ा था.
So, sono is ultrasound.
हाँ, yes.
Sonohysterography. Yeah,
Sonohysterography.
Hycosy. This is the name given to that test. Never mind. Uh,
Mhm.
if high COSY was available to you also, and laparoscopy is available to you, hysterosalpingography is available to you, which one will be your preference?
Sir, my preference will be diagnostic laparoscopy plus
Oh,
that.
okay, good. You must have your good reasons for diagnostic laparoscopy. It gives you much more information than hysterosalpingography, and although it is invasive surgical procedure, but
Surgical procedure.
uh, uh, we have seen it being done in Rashid Latif Hospital frequently.
Yes, sir.
So now here is the patient. Semen analysis is normal, and her FSH is LH, or their ratio is normal as it should be, not abnormal as in PCO. And prolactin level is normal, thyroid tests are normal. And on whatever test, let's say laparoscopy or dye test was positive, tubes are normal. How are you going to manage this patient? I have jumped to management because of the time factor. Yeah,
Sir, for the management, first of all, education and counseling, which should be couple-centered. One thing I will mention, sir, here, the at the time when patient was there, her husband was not with her. I actually took his history on the phone. So first, I'll make confirm that both are present at the time of counseling.
good, very good. You will counsel your patient.
Yes, sir. Sir, I will start
And
counseling.
what will you tell? You have done all these investigations. Now you're going to counsel your patient. What will you tell your patient or the couple? हेलो गायब होगी आ गई आप कभी गायब हो जाती है कभी आ जाती फिर गायब फिर आ गई की हो रही हेलो हेलो हेलो
Uh,
हेलो
Hello?
हेलो आप कभी गायब हो जाती फिर फिर गायब
सर इन्वेस्टिगेशन रिपीट कर दे
हेलो
Hello.
हेलो
Hello.
आई कांट पिक्चर पिक्चर भी आ गई आवाज भी आ गई
Hello, I'm so sorry, sir, for the inconvenience. वो
no
laptop
not
बंद हो
your
गया. I'm so sorry.
not your fault. This is the system. This is the disadvantage of the system that sometimes it doesn't work as we expected, like 100%. Okay, yeah, we go, investigations are all, as you mentioned, normal, and these tests which you mentioned, they are all normal. How are you going to, you said you are going to counsel the couple,
Yes,
not
sir.
wife alone. And what will you tell them?
Sir, I will tell them that the all the workup that we have done, like I will explain their system and fluid analysis and the transvaginal ultrasound and everything. And then I will tell them the conclusion that we have, what is the conclusion which we have found, which I will discuss with the patient, that most probably the anovulatory cycles are responsible for her fertility in whatever the workup is done. So I'll explain her, and for that purpose, I'll make her know that she has to reduce weight. I'll educate her about the weight reduction.
Yeah,
Hello,
good,
sir. आवाज
good.
आ रही है?
I can hear
Uh,
you. So first advice,
and sir,
first is that you will give information regarding all the investigations you have done and their results,
yes, sir.
and then you will suggest to them, number one, weight reduction of the wife.
And yes, sir, weight reduction of the wife and the male as well, because he falls in the overweight and the wife is morbidly obese. So in the weight reduction, not only the diet, I will recommend her diet plus exercise, moderate, and in diet I'll ask her to lower her carbohydrate and the fat portion and
So
increase the
you
protein
know,
diet.
you will advise
Okay, sir.
her to take correct diet. We will not
Correct
go
diet.
into.
Okay, sir. And exercise moderate, like 40 to 50 minutes, 4 to 5 a week. And
Okay.
then I will recommend her tablet metformin.
Weight reduction of weight. How much weight she should lose?
Sir, at least 4 to 5% of the present
Uh,
weight
Absolutely correct.
to make her
You five.
cycles regular.
So irrespective of total weight, we'll go into the percentage that you should lose 5% of the weight. Okay, they come back after 3 months. She has lost 5% weight. Then,
Sir, I will counsel her that she can try for conceiving naturally. That is good as compared to the ovulation induction. But after a discussion with the couple, their wishes and their level of anxiety, like they are facing this fertility for like 2.5 years, then I will recommend her with the ovulation induction and metformin with clomiphene.
okay, how will you how will you do ovulation induction?
Sir, I will explain her the ovulation induction with I'll give her the clomiphene citrate 100 mg from the second day of the periods to the sixth day of the period,
Okay,
and then uh, sir, then I'll give her the injection on the day 7, 8, or 9 of injection follicle stimulating hormone for
all
the.
eh, this will be your first line of action.
Mhm.
Or only clomiphene citrate will be the first line of action.
Sir, first line of action, I'll start with the clomiphene citrate.
For how many months or cycles you will give?
Sir, I will give her at least 3 cycles.
3 cycles. The same dose you started
No,
with
sir, I
100
will. No, sir, I'll increase the dose to up to 150 mg.
up to 150 mg. So first
Yes, sir.
cycle will be, second will be 150,
Yes,
and
sir.
third cycle same again 150.
Again 150 because I started from the 100. I didn't start from the 50
And
mg.
taking that, she should have lived normally with her husband because they are already having quite a 2 to 3 times a week. So
Three
that
times
will
a
be
week.
all right. There are no special instructions about coitus.
Yes, sir, I
I
will.
agree with you. Okay. How will you monitor whether she has responded to the drug or not?
Yes, sir. On the day 7 or 8 or 9, I will give her the injection follicle stimulating hormone, and after the day 9, I will advise her the transvaginal ultrasound to see the follicular tracking. And once the diameter of the follicle reaches 16 to 18 millimeter, then I will advise her the injection human chorionic gonadotrophin to trigger the ovulation. And meanwhile, I will tell her
Do
the.
those patients who go on clomiphene citrate, do they always need HCG injection?
So not always, depending on
No,
the
but
follicular
you will
size. You'll prefer.
prescribe.
I'll prefer.
What will, what will be the dose of that
Sir, human
HCG injection?
5,000 international units.
Good, very good.
5,000.
So this is after you'll monitor and you'll find out that she has not responded to clomiphene citrate. There is no ovulation or whatever you're going to do, TVS or anything. It doesn't show ripe follicles. What will you do then next? They come back after 3 months. It doesn't work.
Sir, as I already prescribed her the clomiphene citrate in combination with the metformin, so I lost this option. So I will now move to the aromatase inhibitors, letrozole. Sir, I will give give her another 3 cycles of letrozole.
So, and monitor in the same way.
I'll monitor in the same way for ovulation.
Then go on.
And if
Then
she, sir, fails these another 3 cycles and she is like she don't want to get the oral dosage, then I can recommend her the injections of like human menopausal gonadotrophin or human chorionic gonadotrophin with monitoring. And if she not even respond to that, and patient is persistent and she want to conceive earlier, then I can recommend her the IUI, intrauterine insemination.
no, but thing is that if the patient doesn't respond to all the stimulations which you have mentioned, first you said clomiphene citrate, then aromatase inhibitors, then injectable. If she doesn't, how is IUI going to help them?
Sir, then again comes the weight reduction of the patient
No,
to make her cycles regular.
he is willing to go along with you, along your advice. How is IUI going to help if ovum does not come out? So it's not, then obviously the dosage has to be increased. Is there anything else we can find out whether all this is going to fail? Is there anything like?
Sir, sorry, repeat the question.
You have tried clomiphene citrate, you have tried aromatase inhibitors, and they don't succeed in stimulating the ovary and producing the egg.
Sir, we can check her ovarian reserve.
Oh, excellent. How do you do that?
Sir, with the measurement of the anti-Mullerian hormone.
What is the normal range of anti-Mullerian AMH?
Sir, 4.5, I think.
You're right. Yeah, it should be above 4.5 or above. That's how it is.
And follicular antral count, we'll go for that.
That you have already mentioned in making a diagnosis of PCO. Okay. In this patient, suppose she does ovulate with your clomiphene citrate, but doesn't conceive. Doesn't become pregnant. You started with 100 milligram and you do follicular tracking or find out that ovulation has taken place. Then what will be the advice?
Sir, she might not be using the fertility window, like the days for proper coitus.
And you will advise her to continue with the same dose because she is responding. Repeat the same dose because with that dose she ovulates. But if she doesn't conceive, then we label her as a case of unexplained.
Okay.
Unexplained fertility. But we persevere with this. So, now almost your time, but I'll summarize. Dr. Dureshwar, you presented good history, but you must prepare next time summary of your patient.
Yes, sir.
Every time you go to the examiner or presentation, have summary ready. because the examiners are bound to ask you the summary. And after that, next thing is you investigated, husband is fine. First line of investigation was your patient's husband. And because semen analysis is normal, coitus is normal, so we set him on the side that he is not responsible for this subfertility. Then you investigated the wife on two accounts. One, for her subfertility. Two, because she is PCO or overweight, metabolic disorder. So we investigated on both accounts what is the cause of PCO or what is to confirm the diagnosis according to Rotterdam. And after confirmation of the diagnosis, we came to the management in this case. Management because husband is normal, wife is normal. In case of wife, we did hormone tests and tubal patency tests. Both were normal. So we counseled, number one, we counseled her about the findings of the investigation that it is a kind of unexplained infertility. And then we suggested treatment. First line of action was that she should reduce her weight. Rightly, you suggested first diet control and exercise. They are the best. And she should lose minimum 5% of her weight, whatever the weight is. If she is, say, 50 kg, then 5% of that will be 2.5 kg. She should lose that. And after she has lost the weight, she comes to you, then because her tubes are patent, we are confirmed by one of those three tests. Your choice was laparoscopy. And then your first thing you suggested was the stimulation or induction of ovulation with clomiphene citrate. You started with 100 milligram, generally 50 milligram is the first month. But doesn't matter. If you started with 100, that's okay. And you monitored stimulation by TVS. And you said the leading follicle should be 18 to 20 millimeter. If the leading follicle wasn't of that size, then you increase the dose from 50 to 100 or 150.
150.
If there was no response, no ovulation with this, then you switched over to letrozole inhibitors. But if the response was there, then we will stick to the same dose and repeat same dose next month. If in spite of ovulation, she doesn't conceive, we labeled her as unexplained in subfertility. For subfertility, unexplained, we continue to stimulate ovaries, whatever clomiphene citrate, aromatase inhibitors are injectables. You said these injections are procured from postmenopausal or pregnant women's urine. But these days they are prepared from recombinant, they are called, in the lab. Recombinant. They are pure. There is no addition of LH in them. There is pure FSH, pure LH. So they are available in the market. So we could stimulate ovaries with gonadotropins, and if the response is there, then we could do IUI. If the response is not there, then we have to find a different regime to stimulate the ovaries. And whether the ovarian reserve is there or not, you did AMH test, which will tell us whether there's sufficient AMH plus the TBS findings. They help us in finding out sufficient ovarian reserve. We did not discuss IVF or any ICSI, anything of that. That takes full one class for a discussion of that, ART and its methods. but you did well. Thank you very much.
Hello.
Thank you, sir.
Hello.
Hey, wait a minute. There are two questions. Let me answer those. Yes, what are
Hello.
those questions?
Hello.
Hey, just a minute. Let me, my secretary tell me what are the questions. Ji,
Hello.
एक minute. Ji, what are? Oh, yeah. Oh, thank you. Thank you for pointing out that. That's most important. Before we go on, if the polyp is there, if it is a small polyp, then we'll repeat TVS after next menstrual cycle. Because sometimes excessive secretory activity shows up as a small polyp. With menses, it may disappear. But if it is a large polyp or if the polyp does not disappear with next menses, then we do hysteroscopic polypectomy and then proceed with the management of her
That is-
weight and subfertility. Yes. So what is
नहीं,
the second question?
अबू एक मिनट मैं थोड़ा सा इसमें ऐड करूंगा.
Yes.
For PCO diagnosis, sex hormone binding globulin or serum testosterone should be done both.
Well, the question is for PCO, sex hormone binding globulin or testosterone. Testosterone test is more expensive, is difficult, and not reliable. That's why easy test is SHBG. But if the laboratory is available, testosterone can be carried. G. Yusuf Sahab.
ये whenever you did, आपने जब ट्यूब चेक करने के लिए लेप्रोस्कोपी की थी, for infertility it is kind of a mandatory के साथ आप हिस्टोस्कोपी भी करो.
इसको भी करते हैं, सबके साथ।
अगर आप वो करते साथ तो probably अगर वहाँ polyp था तो we can remove the polyp in the same sitting. It will make it more easy.
आपकी बात सही, लेकिन मैं तो लेप्रोस्कोपी से पहले अगर पॉलिप टीवीएस पे डायग्नोज हुआ है तो आई विल पोस्टपोन एवरीथिंग टिल आफ्टर नेक्स्ट menses and confirm that polyp is persistent, then go on to laparoscopy plus hysteroscopy.
मैं I'm trying to make a point कि जब आपने आ गया that is fine. डॉक्टर राशिद ने बिल्कुल ठीक कहा कि पहली बार आने से you don't normally advise them कि जाके आप हिस्टोस्कोपी करके इसको रिमूव करा लो. What you do is you ask them to wait for one more cycle and repeat it next cycle के end. अगर फिर भी persist करे then it has to be taken care of. Secondly, जब भी आपने infertility के लिए आपने workup करना है, जब आप उसकी we routinely what we do is कि with laparoscopy we do diagnostic hysteroscopy as well in the same sitting. Hardly takes about 5 minutes तो वो इकट्ठे हो जाता है और उसमें अगर इस तरह की कोई छोटी पैथोलॉजी हो तो we can always take it out.
Thank you, thank you, thank you. It's 9 o'clock. Next class, Dr. Shahnaz ले रही है?
नहीं जी, वो मैंने लेनी है.
आप ले रहे हो?
हाँ, वो इसी को हम कंटिन्यू करेंगे.
अच्छा, चलो. Okay, thank you, thank you. एक और question.
Thank you, sir.
एक और question, एक मिनट.
Please repeat progesterone in cycle.
है?
Serum progesterone.
हाँ, सीरम प्रोजेस्टेरोन उसका सिंपल नाम है P4 on cycle date 21, which we discussed that in a regular normal cycle 21 days okay, but in a patient like this who gets some menses every 2 or 3 months even, so 21-day progesterone will not be providing any information about ovulation, because ovulation in this case, if at all it happens, which does happen in irregular cycles, there can be ovulation, which does happen, but that the test for that will be that it's not 21 days, 14 days before expected date of menses. जी कोई और कुछ कहना चाहता था?
Hello.
जी.
Sir, in that irregular cycle, how we come to know that that is 14 days before the next cycle?
That's what she says. Her menstrual is every 2 months, let's say. So that 21st day will not be from LMP. That will be worked out 14 days before next.
Sometimes she's getting in 3 months also.
Ji,
Sometimes she's getting in 3 months also. So we will do the serial progesterone.
First do it after second month of
Before second
expected menses. If it is negative, then do it next month because that will be for third month as well.
It means
If
the
at all your
serial type of thing.
it will be serial. एक दवा इस
How many,
महीने एक दवा
how many readings?
how many? Generally, such menstrual cycles are anovulatory. So I will not go on repeating fast because you're wasting time. Then 3 months
Sir,
and another 6 months gone, patient will get frustrated with you. So I'll do it only once.
Okay, thank you,
Because
sir.
go on. The treatment should start as early as possible. If you keep postponing investigation, I get a lot of patients from outside Lahore. I try to do all the investigation in shortest possible time and start the treatment because patient's interest is to have treatment. If those practitioners who prescribe treatment without investigation, patients are very happy with them. But we must do investigation, but don't prolong it unnecessarily over a year, over 6 months. Ji,
sir, isn't it serum progesterone done on?
Ji,
Sir, isn't it serum progesterone done on 21st day of the cycle, and then we repeat it every week, and we till she menstruate, and then we take out the mean. Isn't it so, sir?
I don't know. मैं तो एक ही दवा करवाता हूँ because cost factor. If it is negative on 21st day, how is it going to become positive in next 7 days before menses? Because ovulation 21st day is fixed because if on 14th day ovulation has taken place, in 7 days there will be sufficient progesterone in the body for detection. If it is not high on 21st day, then how is it going to rise in next 7 days? I don't know. Because patients' pocket are
नहीं, मैं इसमें मैं would like to ask the doctor साहब